Hello everybody, my name is Weaning I'm with Daytona State Respiratory Therapy Program, and today I will be going through the process of weaning protocol. What I'm going to do before anything actually, is observe the patient's chart and read the doctor's orders. I'm going to knock on the door and introduce myself. Hi sir, my name is Ree from Respiratory. Doctor has an order for a weaning protocol. I will wash my hands for 15 seconds. I will allow my hands to dry. I will identify the patient by looking at his wristband. Sir, can you state your name and date of birth, please? Mr. Legs, that's correct. Alrighty, sir, what we're going to do today is something called weaning protocol, and what that is a test to see if you can spontaneously breathe on your own, so we can take you down to a less aggressive mode of ventilation, which will possibly lead to extubation sometime soon. Some of the risks here of weaning is the tube becoming dislodged. Maybe you might have some anxiety. Maybe you might get a little too overexcited because you're coming off the vent, and you might self-extubate. What that means is your tube might come out. In that case, we do have an extra one here. I also have an ambu at the side of the bed, at the head of the bed, so we can ensure that you'll be well taken care of if anything does happen. Some of the patients that we will see on vents like this would be respiratory failure examples, ARD, COPD, CF, pulmonary embolism. Some of the weaning parameters that we want to be sure of before we follow through with the weaning is lung mechanics. We want acceptable lung mechanics. We want respiratory rate less than 30, tidal volume 4 to 6 mLs per kilogram of body weight, RSBI less than 105, PEEP less than 10. We want NIF, which is negative inspiratory force, also known as MIT, maximum inspiratory pressure, of negative 20 to negative 30. We want minute ventilation, 10 to 15 liters per minute. We want normal vitals. Excuse me. In this situation, my patient is on AC mode with a rate of 12, tidal volume of 500, FiO2 35, PEEP of 5, i.e. 1, 2 to 1. And he actually has minimal vent settings, which is something that we want to see in order to follow through with the weaning process. We want adequate oxygenation. We want his oxygen rate to be okay. We want him hemodynamically stable, which means a normal ABG, which I have here as well. 739, CO2 is 40, and bicarb is 25, which is acceptable. We also want him to be mentally alert. We do not want any sedation. If he is on sedation, that will follow through with risks as well. The patient will be lethargic. He won't be able to follow commands when we're telling him to breathe or following through with any of the lung mechanic tests. My patient is a very good candidate, and we're going from AC mode to CPAP mode. So at this point, what I'm going to do is change the mode, and I'm putting him to CPAP. We're having a PEEP of 5 and a pressure setting of 10. We're going to do this for 30 minutes from 30 minutes to 2 hours max. After the 2 hours max, or 30 minutes, depending if the patient fails or passes, we will then return him to his previous mode, which in this case is AC mode. We want to monitor the patient while we have changed his settings. We want to make sure that his vitals are all acceptable, his breathing pattern is normal, his vitals are within normal range. We don't want to see any accessory muscles. We don't want to see increased work of breathing. We don't want to fatigue the patient. We want to make sure that he is stable. With also doing this, per your hospital's protocol, you might want to obtain an ABG somewhere between 30 minutes to an hour. 30 minutes to an hour to ensure that your patient is hemodynamically stable. If the patient can maintain the proper oxygenation and gas exchange at this level, then we consider that they have passed the spontaneous breathing trial. At this time, I have changed the patient. It has now been 2 hours. I will come back, change him. All right, Mr. Legs, you passed. This is fantastic. We'll change him back to his AC mode, and we will do this trial again perhaps tomorrow. I will go ahead and deglove. I will wash my hands. All right, Mr. Legs, we'll come and check up on you in a few hours, and I will go to my desk and document any positive or negative changes that happened during the spontaneous breathing trial. I will also communicate with the nurse and the doctors and let them know about the progress and maybe suggest a possible extubation sometime in the near future. That is all. I thank you very much for your time.